Onychomycosis is a common fungal infection of the nails, primarily affecting the toenails but sometimes also the fingernails. It is a condition caused by different types of fungi, including dermatophytes, yeasts, and non-dermatophyte molds. This disease can affect anyone but is more prevalent among older adults, individuals with weakened immune systems, and people with predisposing conditions such as diabetes, peripheral vascular disease, or a history of nail trauma. Onychomycosis is not only a medical concern but also a cosmetic and psychological issue for many patients, as it can significantly affect self-esteem and quality of life. Etiology and pathophysiology. The primary causative agents of onychomycosis are dermatophytes, with Trichophyton rubrum being the most common. Other species such as Trichophyton mentagrophytes and Epidermophyton floccosum may also contribute. Yeasts like Candida albicans are more likely to infect fingernails, particularly in individuals with chronic exposure to water, while non-dermatophyte molds such as Scopulariopsis or Fusarium can occasionally cause nail infections. The fungi invade the nail plate, nail bed, and surrounding tissue, leading to thickening, discoloration, and separation of the nail from the nail bed, onycholysis. The infection often begins in the distal or lateral edges of the nail and progresses proximally. Fungal colonization results in the production of keratin-degrading enzymes, which break down the nail structure and create an environment conducive to further fungal growth. The immune response of the host can vary, with some individuals exhibiting minimal symptoms, while others develop significant nail deformity and discomfort. Clinical presentation. Onychomycosis can present in various forms, classified into four main types: distal lateral subungual onychomycosis, DLSO, proximal subungual onychomycosis, PSO, white superficial onychomycosis, WSO, and total dystrophic onychomycosis, TDO. The most common type, DLSO, manifests as thickened, brittle, and discolored nails, often with debris accumulating under the nail. PSO is more common in immunocompromised individuals, including those with HIV/AIDS, and appears as a white discoloration near the cuticle. WSO shows as superficial white patches on the nail surface, while TDO represents the final stage of the disease, characterized by complete nail destruction. Patients may report nail pain, difficulty walking, especially in toenail infections, and susceptibility to secondary bacterial infections due to nail fragility. In some cases, the affected nails may emit a foul odor. Despite these symptoms, the infection is often painless in its early stages, which can delay diagnosis and treatment. Risk factors. Several factors increase the likelihood of developing onychomycosis. Aging is a major risk factor, as the nail grows more slowly and becomes more susceptible to infection over time. Other contributing factors include poor peripheral circulation, diabetes mellitus, a history of athlete's foot, tinnitus, immunosuppressive therapy, repeated nail trauma, and prolonged exposure to moist environments. Genetic predisposition may also play a role, with some individuals showing increased susceptibility due to variations in nail structure or immune response. Diagnosis. Diagnosis of onychomycosis typically involves a combination of clinical examination and laboratory testing. Clinically, characteristic nail changes can raise suspicion, but confirmation is necessary, as similar nail disorders, such as psoriasis or lichen planus, can mimic fungal infections. Laboratory methods include potassium hydroxide, KOH, preparation, fungal culture, and polymerase chain reaction, PCR, testing, which help identify the specific pathogen and guide treatment decisions. Treatment. Management of onychomycosis can be challenging and often requires prolonged therapy. Treatment options include topical and systemic antifungal agents. Topical treatments, such as cyclopirox, efinaconazole, or tavabarole, are generally effective for mild infections but may be less successful in severe or thickened nail disease due to poor penetration. Oral antifungal medications, such as terbinafine and itraconazole, have higher efficacy, particularly for DLSO and TDO, but require monitoring for potential liver toxicity and drug interactions. In addition to pharmacologic therapy, adjunctive measures such as mechanical debridement, laser therapy, and proper nail hygiene can improve outcomes. Preventive strategies, including keeping nails dry, wearing breathable footwear, and avoiding shared nail tools, are essential to reduce recurrence. Complications and prognosis. If untreated, onychomycosis can lead to permanent nail deformity, secondary bacterial infections, and impaired mobility, particularly in elderly or diabetic patients. Recurrence is common, with up to 25 to 50% of patients experiencing reinfection within a few years. Early diagnosis and adherence to treatment regimens are critical for successful outcomes. In conclusion, onychomycosis is a prevalent fungal nail infection with significant medical and psychosocial implications. Its management requires accurate diagnosis, tailored antifungal therapy, and preventive strategies to minimize recurrence and complications. Despite its chronic nature and potential for recurrence, effective treatment can restore nail appearance, improve patient comfort, and enhance overall quality of life.